my great pleasure, and I want to thank previous speakers for having done all the work. This is a talk which I've crafted to convince the horrendously skeptical neurosurgical community about the validity of the things that we're talking about. So if people have heard this before, I apologize, but I actually am happy with the way it's come out. So all of these things work together, and what cause and what is effect, what is genetics and what is mechanics, all of those things are yet to be completely described and defined. And I'll not live long enough to have completed this work, but I'm going to do the best that I can in the time that I have. This is a history of my relationship with this. I was seeing babies, small children with severe Chiari decompressions after they had been wrecked by previous surgeries. And they kept being operated on again and again and again as they got older. And so the first step, this is my favorite quote. A scientific truth does not triumph by convincing its opponents and making them believe, but rather because its opponents eventually die and a new generation grows up that is familiar with it. That's how a scientific truth grows, so you have to keep going. I think this is the modern equivalent of the myth of Sisyphus. You keep rolling the boulder up the hill and it falls back down and you just keep rolling it up again. So this is a 9-month-old child that I saw who had gotten so much worse after he was having to go for a trach and a G-tube and all of those things. And the back of the head looked great. The Chiari decompression looked great, but the patient was worse. And so what you see there is that the odontoid process Jared described to us is actually pushing into the front of the brain and really destroying the ability to swallow and these things. And I went to the autopsy things, not for this baby, but for in general, to see what the movement of the occiput and the odontoid process was, and showed that there was a lot of movement available there. And so what we did with Brian, and I just saw him, he's now 24 and a very successful person. So what we did is we reduced him so that angle changed, and then did a fusion from the occiput to C2, or C3 actually in this case. At that time we had to use halos and these sorts of things, but that sort of was an epiphany to me that we really had to start looking at Chiari as not just the herniation of the cerebellar tonsils, and accept the fact that if it looks good in the back, it's going to look good. So that's been my mantra. I published this, and Dr. Millerod called me after it had been done, and he thought he was an epiphany too. Didn't give me credit for it, but that's what ended up with it, that was discussed in his seminal paper on the hereditary disorders of connective tissue and its relationship to Chiari. So what are the indications for the occiput to C2 fusion in patients with Chiari anomaly? We have a lot of discussion about that. But at least 5 millimeters, this is what I use now as the decision making if we come up with a patient who has a Chiari and they have I want them to know that they would need an upfront fusion if there's at least a 5 millimeter descent of the cerebellar tonsils, abnormal measurements of Occipito cervical instability that we're working on and we're developing consensus about, severe neck pain and headaches that is made worse by mechanical nature. In our area, with all of the potholes, you can always tell about one of these patients because they've been screaming on the way to the office because of the bouncing. And they all get a month of cervical collar to see whether it helps. So they have to have severe incapacitating headaches, they have to have mechanical nature to the pain, and they have to have improved with a cervical collar. I get a flexion extension MRI to see whether there's movement. So it's important that well, except when you're talking to neurosurgeons, I'm sorry, many of them you have to speak in short sentences. You know, it's sort of like that. I didn't want to quote Sarah Huckabee Sanders, though. I tell the patients that they're suffering with pain and they're not in imminent danger of death or severe neurologic deficit. So we're talking about functional neurosurgery, the ability to make the quality of life better. All patients have had significant difficulties with their quality of life. And the only neurologic deficits that we used at the time was that they had problems that are related to the Chiari, like swallowing difficulties, like tinnitus, like numbness and tingling in the hands. We didn't use any of the other 100 things that they have come complaining of from time to time. So this is the critical paper by Tom Millerot and Paolo Bolognese and Claire about joint hypermobility and connective tissue disorders, and what it resulted in is a huge influx of patients with EDS into the Chiari Institute for treatment. And I arrived there in 2011, and there was a gift to me that this had already been established, and that this is one of the go-to places, one of the few go-to places to get care. So I had an opportunity I came with a lot of skepticism myself, but it's hard when you see what they come with and what they go home with, not to be believed. So you've already know about the diagnosis of joint hypermobility. Now, these are my grandchildren. But I always start with a conversation. I spend a lot of time talking, and there's a table between me and the patients, and almost all of them will sit there all the time with this like this, and it's just, that's another epiphany. If you have to hold your head up, they can't text. These young people are really unhappy because they can't text because they can't look down. And so it gets worse. So that's what the consultation looks like, and I thank my grandchildren for their help with this. So we have 94 patients from 2013 to 2015 with a follow-up of at least a year, and 27 of those patients were patients who had previous surgery, and although they had normal-looking posterior fossa things, there was no compression of the cerebellum from the back. They were functionally worsened. They usually had a honeymoon period of a few months to a year, but they always got worse because there's an increasing instability when you take down the muscles in the back of the head. And Fraser Henderson calls what we see now in the EDS population, he calls it the cervicomedullary syndrome. And I didn't want to start off with that because I was skeptical that was real. And so I called it the Sarah syndrome because I first recognized it in a patient named Sarah. And it's hard for me to abandon something I've already thought of, but I think that the more I get along, the more I agree that Fraser was completely right from the start. It is a cervicomedullary syndrome. So they have all of these things. In defining Sarah syndrome among a subset of these patients who had EDS and this is only a subset, it's about a third of the patients that we see, they all had postural instability of pulse and blood pressure, dizzy spells, they all had chronic fatigue, and they all had some cognitive impairment with memory and some confusional state. Many of them had irritable bowel syndrome, they also had gastroparesis, they had inability to initiate urinary streams, and lately we've become more and more aware of the mast cell dysfunction. And we've also seen recently, and this is new news, the problem with coagulation, either blood clots, pulmonary emboli, deep vein thromboses, and so their coagulation profiles are abnormal. So we have 25 patients, and these are the criteria. So we looked at what we've done. We do intraoperative reduction and then fusion of the occiput to C3, C2 usually, sometimes C3 depending on the anatomy. And all of them had their clivoaxial angle improved. and all of them had the ability of the odontoid to push backwards improved in these patients. Their Karnofsky score, which is a functional outcome of how well you feel your life is. And you have to have, in order to be operated on, we need a Karnofsky score of 70 or less, which means you need help with getting some through the day. You can't go to work and you can't go to school every day. You have to come home or not go at some point. So this is what happens with it, and I was sort of amazed. About 2/3 of patients with instability, postural instability, that is POTS, had a major improvement in their POTS. About 2/3 of them also had a significant improvement in their gastroparesis, in their irritable bowel. About half of them had marked improvement in their memory loss and brain fog after the function. And the pain was 80% nearly 80% of them had chronically improved pain management. At the pain for that was the craniocervical junction. They have widespread pain in other areas, which I don't have any responsibility for. I would love to be able to do that, but I can't. So the most, let's see if I can get this. Oops. Let's see back. One of the. Yeah, any help you could give me would be. I want to play the video. A pediatric neurosurgeon got up in a meeting where I presented it and started sort of screaming at me that you've ruined this patient's life forever because they won't be able to move their neck, they won't be able to drive a car, they won't be able to do anything. So this is more likely in the EDS population than this is a fused patient. She's a year out. And while you can see that she has to actually turn a little bit when she's moving her neck, she's a completely functioning individual. So, and I have not seen any one of my patients who hasn't been able to drive after this surgery. So some thoughts of the future. This is another set of epiphanies, and it's so early. But look at the clinical uses of vagal nerve stimulator. First of all, we know that all of the things that we're talking about in Serra syndrome have to do with the cholinergic portion of the autonomic nervous system, and that's the vagus nerve, and it also comes out of the conus medullaris near where the tethered cord is problematic. So that part of the autonomic nervous system is certainly part of where we're talking about. So this is all so. It just came to me, and I had to tell people because I got to get somebody else to help me do these things. The vagus nerve stimulation is FDA approved for intractable epilepsy, for refractory depression, for multiple headache types. Now they're also using stimulation of the stomach for gastroparesis and of the bladder for inability to initiate urinary streams. But what they're really doing, if you look at what's done, is that it's the vagus nerve that's innervating is around the stomach. If you want to do a vagotomy for a gastric patient, you do it at the gastroesophageal junction. I don't know. This is crazy. But you're hearing it here first. There are human trials of an animal studies on vagal nerve stimulation for rheumatoid arthritis, for a number of cognitive disorders like brain fog and memory difficulties, for chronic pain syndromes of all types, now that we have it FDA approved for chronic headaches. And now we see there's a study from the Feinstein Institute, which is the research institute associated with Hofstra, to do it for bleeding disorders and animal models of bleeding disorders because it changes the coagulation profile. So I think that there's hope. I think that the first thing is to break into the reluctance to do anything new. And that Lyrica ad, which says, everybody else says I look like everybody else, but I don't feel like everybody else, and we got to get over that. So anyway, this is what I've done, and I'm trying to continue. Disorders of the autonomic nervous system should be seen as neurologic deficits. Neurologists and neurosurgeons want to be able to identify where these problems arise. And I think they rise in the brainstem at the level of the vagus nerve nuclei. And I think that we have to look at them like that. Early results suggest cause and effect problems at the foramen magnum in complex disorders of the autonomic nervous system. I'm sorry I put the type 3 Ehlers-Danlos syndrome in there. I will change this slide for the next time I give it. But I also am trying to convince, and I've got some of the real leaders in pediatric neurosurgery to buy into that. They promised me that they will do assessment of joint hypermobility in the patients that they treat for Chiari initially. Now, whether they do that or whether they were just trying to get me out of the room, I have no idea. But I really appreciate the opportunity of letting you all know what's happening. And I have hope, and I hope you all have hope. Thank you.